CRA's 2025 annual scientific meeting in Calgary, Alberta. Hosts Dr. Daniel Ennis and Dr. Janet Pope welcome special guests to bring you a daily roundup of the highlights from the ASM. This episode has been made possible in part by Sandoz. Thank you, Sandoz, for your generous support in sponsoring this episode. The scientific integrity and objectivity of all podcast content is overseen by an independent CRA committee to ensure the highest standards.
Welcome to this special edition of Around the Room. We're coming to you with daily roundups of the most interesting and essential topics from the CRA's annual scientific meeting here in downtown Calgary, Alberta. We've taken Around the Room on the road this week, and I'm very happy to be joined in person by my very excellent co-host, Dr. Janet Pope. Welcome, Janet. How are you?
Great, and it's great to be here in the Chinook time.
Oh, yeah, that is quite nice. I thought it was going to be a lot colder than it ended up being. And it's really nice to see you in person.
Likewise.
And so for the whole week, we're thrilled to have with us two of our very best scientists to help break things down for you. The University of Alberta's Dr. Mo Osman and the University of Calgary's Dr. Marinka Twilt. Dr. Twilt is the ASM Program Committee Chair, and Dr. Osman is the Abstract Chair and Co-Chair of the ASM Planning Committee. Welcome to you both. Thanks for being here.
Thank you for having us.
Thank you for having us.
So, with that out of the way, I'd really love to get your input on the first day of the proceedings. So, Dr. Twilt, let's start with you. What session caught your attention today?
Well, I'm totally not biased as a pediatric rheumatologist, but I thought it was great that in the year of review, there was now a pediatric rheumatology review as well. And I thought Dr. Rumsey from the University of Alberta did a really good job today and really highlighted some of the important pediatric studies, but tried to also give it a little bit of a twist with including some of the adult studies, such as the new guidelines for systemic JAA and also adult onset Still's disease, which I think makes it not only applicable for pediatrics, but also applicable for adults. So I thought that was a really nice session, but I'm totally not biased.
And I'm always horrified by how much I learn at years in review, because these are things that are published that I presumably should have read as a so-called expert, that adult onset stills can have significant pulmonary involvement. I'm sure most of the rheumatologists listening already know that, but it was specifically mentioned in the guideline that we should consider screening for lung involvement, and that definitely kind of piqued my interest there.
So will you?
If symptomatic, as
So
as per
screen.
guideline.
As per guideline.
As per guideline.
That's a good answer.
Great. So that was certainly an interesting topic. And Dr. Osman, maybe we can turn to you. Any session that stood out to you?
Yeah, so also I'm not biased at all, as the session that really caught my eye was the session by Dr. Choi from the University of Calgary, where she gave the basic science, or not so basic science, as she said, year in review. And what I really loved was how she just deconstructed how multi-omics approaches can be utilized and with incorporating AI to actually answer good hypothesis-driven research. And one of the things that she really touched on was this EXIST, which is a modification when overexpressed, can at least help us understand why immune dysregulation, a lot of the rheumatic diseases, can potentially happen in women more so than men.
That's a kind of a pretty fascinating general concept that I was totally unaware of. And it is something, though, that we observe, that there are sex differences between a lot of our different diseases, male over female, and in some of the spondyloarthropathies, and female over male in some of the seropositive diseases. So that was actually quite fascinating. So Dr. Choi, who I believe is winning an award this year, she was a resident when I was a rheumatology fellow. And it was obvious even at that time that she was a great deal smarter than me. So it's really lovely to see her giving the year in review. Great. Maybe we can switch back to Dr. Twilt. Anything else that was of particular interest today or caught your eye?
I always feel very humbled by Jeopardy because I always have the wrong answer, especially for the OA studies or other studies. So I always feel that that's such a nice way to actually gain a lot of knowledge, because I think these questions are all like so pertinent to us, but they're so specific that it really is hard to know the answer. And then it's brought in such a nice way by Philip every year that I hope he will continue to do this until eternity. But that session always humbles me a lot in like what I actually don't know and I really should like look up or at least remember after the session.
That's very true. I think the medical mystery is also, the case starts out and I go, I know this one. So obvious. I can't believe they don't know what it is. And then I'm completely wrong.
And I think I killed off a couple people in medical mysteries by what I would have done. So I wasn't on the same page.
Yeah.
Me too, yeah. And I think I also would have made, maybe the right decision, but let myself be led by the people who did the wrong decision, which is also very interesting to see the peer pressure that you can see in the app sometimes.
Absolutely. Mo, any other abstracts or any other parts of presentations today that you thought were interesting?
Yeah, no, that's so the mysterious cases I thought was really interesting. The one that really caught my eye, which I think is really relevant to, I would say, every rheumatologist, is the case of PML. So PML, JC virus or polyoma virus infecting the brain is very uncommon. And yet we prescribe a lot of immunomodulation in patients with, in this case, lupus. So things like azathioprine and rituximab are not reported to have frequent PML associations, and yet this poor patient developed PML, and it's very devastating. As someone who's managed PML in patients, it is a very devastating complication related to our therapies. So I thought this was a really good educational case.
Janet, you pay close attention to all these sessions.
I did indeed, and I was Xing away, so there's lots of pearls and wisdom on X from these sessions. So a couple things. So shout out to Claire Barber. So again, well represented the Western crew on the year in review. So a couple things that Claire talked about. First of all, they all had interesting search strategies on how they were going to present the year in review. And Claire, from her research and knowing the researchers around her, did look at inequities, the First Nations people and access to care and wait times. She discussed a lot of Canadian publications that really made me feel very proud, some of which I knew and I didn't know all of them. So she was able to talk about that. And then when May Choi talked about there might be a new antibody, of course, until it's looked at further, this isn't ready for prime time, but the anti-SPEN antibody in systemic sclerosis that seemed to really be associated with digital ulcers. And, if that pans out over time, maybe we'll have some kind of treatment that can at least dampen an autoantibody to help those patients. So they were a couple of my take-homes. I'm always proud of the people doing these mysterious cases because they all kept on time. They were pertinent and relevant. They showed the pathophysiology where appropriate instead of just saying, oh, well, we have the slides, but I didn't bother getting them. So I thought they did a really, really great job.
There were kind of two topics that were touched on today that I'd love to get all of your input on. So one of them was planetary health, and there was some important kind of Canadian literature on that. What was kind of, I'm curious kind of what you took away from those sessions.
Yeah, I think it's a very important topic, and I think we really have to look better. And I think that's still the problem. I think we know a lot of what we have to change, but I don't think we know what actually will make the biggest impact. Because at one point people were like, maybe meeting in person is not the right thing, but the amount of actually planetary not health that is associated with that is much smaller than actually having a clinic one day in the week, right? So I think that's where I still struggle with planetary health is where can we actually make the highest impact? And I think that was the message, at least that I got from Claire as well, that we need to do something and we really need to look at where we can actually make the impact, where it has the most effect.
Yeah, I agree completely with Marinka. I feel like there is a huge problem that I think has been identified, and I feel like we have to kind of collectively think and put our heads together for how we can really kind of derail this problem.
And I think a big take home, so Sasha Bernatsky, again, a shout out to a great Canadian researcher in this area. There's other people really passionate in the Canadian Rheumatology Association, but showing that the air pollution, frankly, so the total suspended particulate matter, that when it's bad, you get an increased onset of RA and probably a whole bunch of other stuff, not just lung diseases, and you can flare more when things are bad. And because of natural disasters and fires all over the place, this is going to affect more and more people, and it's a small effect compared to the direct pollution and the death rate of obstructive lung disease when it's really poor air quality. But I think it shows that so much of what we do ripples on so many other things, because who would think autoimmunity would change if there's air pollution, right? It's not something I'd be thinking of directly, and it can be directly measured. So I think that we have to kind of, in our own part, do what we can do. We probably have to modify how we buy our food and the packaging, but there's a lot of waste in the hospital system, and we have to be clean or sterile depending on what we're doing, but for clean procedures. But how much of what we do really has to be done with all the waste wrapped around it? It's really hard to say.
Yeah, I thought that was I'll ask you in just a sec, but I thought that was really fascinating, because I think something like asthma, where you think of like, oh, air pollution, you breathe that in, it touches your lungs, and therefore you have an asthma flare. Like, obviously it's more complex than that, and asthma has an immune and allergic component to it. It maybe isn't that surprising that there's a link between, particulate matter and environment and immune system. But I don't think that was obvious to me. So it's actually nice to see some literature that connects those things that you wouldn't necessarily notice obviously in your clinic. I wouldn't notice, there's more people coming in with flares when there's wildfires in BC. So I thought that was really fascinating.
Yeah, one of the things that came out of Claire's talk as well for me was how the environment and the food intake potentially changes the disease or the disease response per se. And I think that's something that has been kind of resonating, I would say, on the basic science side a little bit more. But now it's really nice to actually see that some clinical studies are actually paying attention to this also, because maybe this has a big role on how we can actually better treat our patients, and potentially even like in early rheumatoid arthritis, one of the thoughts I was having was, well, how can we actually try to start derailing the disease and changing things using those types of interventions related to diet and so on.
The keynote address was on artificial intelligence, and artificial intelligence had come up in some of the previous talks. Maybe Janet, I'd love to hear maybe some of your takeaways from that talk. How much do you use AI in your clinic?
Right. So I think we use AI all the time without really realizing it. It's because there's hidden things within scheduling. You send an email and without even Grammarly or something like that, words just start popping up, right? There's a lot of AI that I think is behind the scenes. When it really comes to, when I say grunt work, I'm not saying it like demeaningly, but the work that probably none of us like, the paperwork or the notes, that they're very repetitive. I should be implementing more AI. I should have a chat equivalent of every time patient asks whatever, here's insert this. And I've tried to do macros. It's not really AI, but if the patient has anemia, low MCV, here's what we always tell them. So I have that saved and just cut and paste it in. But I'd love to think of a chat bot. I haven't used AI Scribe, one of our colleagues has, but it did hallucinate. So you have to start reading the letters and making sure. So it had talked in this note, it had talked that the previous doctor the patient had seen, that the patient didn't like them, et cetera. And the patient didn't even really say that. I think she had moved or something and changed doctors for that reason. So it did hallucinate a bit. Yeah. And that's a little bit frightening, I think, because I honestly don't want to reread the notes. I want to just get it done and get it out. But I think there's huge opportunity. I really feel that the younger ones will embrace it more than I will, because they seem to be more gizmo oriented in a good way. But I think, like, honestly, there's so much stuff we do on forms and other things that I think we could just get right off our plate, but still have it done effectively and properly for the patients.
Mm-hmm. Like trainees who may do notes for you too can hallucinate also. So
They do.
Yeah.
They do.
Yeah,
In fact,
so-
well, usually they don't hallucinate, but they don't really put anything in the note. HPI is empty.
so
Meds, they didn't bother. They said same, and they should know that the word of wisdom is same means I don't know.
what were your two take on the kind of AI content that came up today?
I thought Dr. Mamdani gave a very excellent lecture. It was mostly clinical applications. I had the fortune of actually having him speak earlier today on research application. I think there is a lot of future in it. I think we just have to realize the pitfalls of it, because I think people don't realize if it's open source, it's out there in the ether for everybody to see. So I think those are things that we really have to realize if you use it for like writing your paper or writing your grant is out there and people can potentially use your idea, right? So, and there are other things that you can use a local application so it's on your computer. I have to say I'm also not the most savvy AI person. I'm trying to use some of it, but the problem I think for us busy clinicians and researchers is that it also takes time to learn it. Right, and I think that's the problem, that although you might want to, like Janet says, you might want to use it, just to build it into your workflow is going to make you slower in the beginning, and then you have to have that patience to actually do it, and also the time and the opportunity to do it. But I was very optimistic after his talk, but also very aware that I needed to make sure that I knew what the pitfall and the challenges were of using AI.
So I think one of the things I really enjoyed about Dr. Mamdani's talk was that near the end, he actually provided resources. So how do you overcome these pitfalls? So one of the things, for instance, I've used AI in the research setting, particularly helping us kind of predict things, biological pathways and things like this. I do not use AI when I write. In fact, I actually tell my students, you are not allowed to use AI, because I want them to learn how to write the old-fashioned way first and actually synthesize information before they actually learn how to use the AI. The other thing that I thought he published was some of the problems or challenges related to AI, particularly how AI can be trained, I guess, to racially discriminate, I guess, potentially in certain settings. And this, I think, is important to remember, that obviously if you train the AI in a certain way, the AI will only do what you ask it to do. And especially if you're trying to train the AI with 5 different senses, I think we still have a long way to go. But I think it's really cool because it can at least be eyes and ears for rheumatologists, where we have a lot of access issues for our patients. So this could potentially be helpful in that way. Eventually down the road, I just don't see it. It's not ready for prime time.
Yeah, it struck me that like sort of one of the concepts was kind of bad information in, bad information out. So it kind of suffers from like the same issue as like a meta-analysis, which is like you can get a result and it's quote unquote scientific, but if you fed or taught your AI wrong, it's going to give you bad information. If you ask the wrong question, it's going to give you bad information. I do think that there are, I have heard people be, anxious about like, oh, it's going to take over our jobs. There are parts of the job that I think it would be good if it took that over, right? The idea that it was superior to a neurosurgeon or neuroradiology or whoever at finding, early brain bleeds. That's good for everyone, right? Like, so for us, I'm not sure what that's going to be. If it's going to be, early joint erosions or, rheumatic joint disease, or if it's going to be looking at a CT angio and saying this actually does look like vasculitis, not just atherosclerosis. Anything that gets us closer to the cosmic truth of what's happening in someone's body is actually, I think, overall valuable. And yeah, you're right. Like, it is hard to actually pause your clinic, learn to integrate a new tool, learn a different way of writing your notes and interacting with patients. Though, he made a good case that people seem to largely like it. Patients seem to largely like interacting with it better than many of us, right?
And the reduction of error, that really hit me, that our diagnoses, I always try to tell the trainees as a sort of a pearl again, is I say this is possible rheumatoid arthritis. We've never witnessed swelling. You know, they brought in the blurry pictures and you go, is that your arm or your ankle? I can't even tell, right? It looks swollen, but I'm not sure what I'm looking at. So they bring in, you know, anything on their cell phone. But I always say, make sure we're intellectually honest, or else we have blinders on, that this is beyond any doubt RA, and they've been in long-standing remission. This one's possible lupus, and here's why, here's the features. And I think that probably helps to reduce this sort of diagnostic pathway we go down and then we put blinders on and don't think of anything else. Because if we're wrong about a third of the time, even as subspecialists, that's a little bit concerning.
And like, I think one of the things that I also really enjoyed was how he emphasized buy-in from the end users. And I think this is very important because it gives us an opportunity to actually advocate for our patients in different ways.
I think that brings us to the end of today's session. Are there any sessions you're looking forward to for Thursday?
I'm of course looking forward to many sessions tomorrow. One of them is the debate. I think that's going to be very interesting. So it's going to be a debate on be it resolved that MSK or POCUS should be a mandatory component of rheumatology curricula. So I think that is going to be a very interesting statement and interesting discussion between the people. And then of course there's multiple workshops, and I think I cannot actually mention any because I think all of them are great, and I don't want to single out one. I'm sure Mo will single out the abstract one, so I'll have them do that one. But I think it's fantastic that there are so many workshops, and the quality of the workshops, like, it looks so amazing. So I'm really happy about that. And the keynote speaker, but I'll let Janet talk a little bit about that.
Oh, sure. So there was an NIH guest invited who, with NIH travel ban right now, couldn't come. So we're going to have our own Nancy Malthouse, who will be doing a state-of-the-art on cellular therapies. And she's worked for a long time now in Ottawa with the stem cell transplant, autologous stem cell transplantation in especially the systemic sclerosis patients. She's learned a lot. She's done extra training in this area. And I think it'll be fantastic. So I'm sad maybe that the other person couldn't come, but I think this is great, and I'd like to highlight that.
Yeah, and I just want to say, as ASM chair, we're so grateful for Dr. Malthouse because there was no hesitation, and this is the community, right? The CRA has such a great community that last minute you have to find somebody new, and then of course I can do that. And would this not be a nice topic? And we were all like, fantastic. So thank you so much, Dr. Malthouse.
I wanted to echo this to Dr. Malthouse, esteemed colleague in systemic sclerosis landscape in Canada. She's fantastic, great speaker. I also wanted to emphasize that, again, as abstract chair, we are trying something new this year, where we're doing these abstract workshops, so more people can actually get to present their work at a podium type of setting. The other things, of course, are, remember, bright and early, we have our podium sessions, lots of cool kind of primary research that lots of people are going to be presenting, so that's exciting.
And I do have to plug the CRA workshop, so totally biased because I'll be giving it, but it's on knowledge translation, and really research in a vacuum is a total waste of time and money. No one's paying for proper knowledge dissemination, so we're hopefully going to have a discussion about that. But also just on keeping up how difficult it is, and as subspecialists in an area, and we can't even keep up in our own area. Think of the generalists and the primary care, et cetera. So hopefully it'll be a fun workshop, and it's competing with excellent workshops, but I think I'll have more than myself there.
We should just remember tomorrow is the AGM, so Thursday is the AGM, so please join us for the AGM, which is going to be at 3:15 to 4 o'clock.
That sounds great. I'm really looking forward to all those. So that's it for this special ASM edition of Around the Room from Calgary, Alberta. Special thanks to the podcast team, Dr. Dax Rumsey, Dr. Janet Pope, Dr. Mo Osman, Dr. Marinka Twilt, David McGuffin of Explore Productions, and Aaron Stewart. Our theme music was composed by Aaron Fontwell. For more information on the important work of the Canadian Rheumatology Association, visit rheum.ca, and be sure to follow us on social media. I'm Daniel Ennis, and we'll chat again tomorrow.
And that's a pod.